Hi, everyone. We will be starting shortly.
All right. Sorry for being late. Patient care can be unpredictable at times, and that's what I'm dealing with today. But my name's Trygve Dolber. I'm a member of the Health Services Research Center here at UH. I'm going to go ahead and introduce our speaker after I give you a little bit of housekeeping. First, this webinar is being recorded and will be available to view from the UH Research and Education Institute website. And second, please mute your microphones throughout the presentation. If you need any technical assistance, please contact the R&E team, Nicole Bollinger or Abigail Zona, who are on the call. If you want to ask questions, you can type them in the chat. Questions can be seen by all attendees, and you have the options to submit them anonymously if you prefer. With all that said, it's my pleasure to introduce Julie Lauffenburger, PharmD, PhD, an associate professor of medicine at Harvard Medical School and an epidemiologist, lead investigator in the Division of Pharmacoepidemiology and Pharmacoeconomics at Brigham and Women's Hospital. Her work focuses on medication optimization, including adherence and deprescribing, where she has expertise in pragmatic trials, implementation research, observational studies, and prediction approaches. Specific areas of interest include developing and evaluating scalable behavioral interventions to improve healthcare delivery, especially using technology. On a personal note, as someone who tries to develop scalable behavioral interventions to improve healthcare delivery, I really enjoyed hearing her talk a couple of years ago at the HSRC Summer Scholars Program. So without further ado, here's Julie Lauffenburger.
Hey, thanks so much for having me. I'm looking forward to sharing some of this work with you today. It's a build actually, I think, on what I presented a couple of years ago, which I think is kind of neat to see the evolution of how different projects can build on each other. And so, yeah, thank you for the introduction. What I'm going to talk about today is a couple different projects where we've been working tailoring different electronic health record tools with a focus on deprescribing. I don't have any conflicts of interest to share. And so just to make sure we're all on the same page, I know there's a mix of clinicians and researcher types. Particularly interested in potentially inappropriate medications. They're widely used, and there's different behaviors really associated with them. I like to use this cascade of how prescriptions are written, how patients fill prescriptions, and patients continue to take medication. So roughly 25% of US older adults, and this is also a problem internationally as well, annually fill at least one potentially inappropriate medication. Some of the most common and nefarious are benzodiazepines and sedative hypnotic Z drugs, often used for sleep. So not only is this sort of a new use problem where we're prescribing these medications, but many patients continue to take them sort of over the long term, which continues to really contribute to this sort of overuse problem. For example, roughly 4% of older adults are taking benzos regularly, 3% are taking sedative hypnotics, just as by way of example. So there's numerous consequences of overuse. These are the focus, one of the two of the three areas of focus today, and they're known to be associated with different health consequences. It's hard to characterize them to some degree, but there's general consensus that they can increase the risk of falling, which might lead to inpatient hospitalizations and other sort of bad outcomes, as well as decrease in activities of daily living, as well as an increase potentially in the risk of cognitive impairment, which is a patient-centered sort of issue that older adults care a lot about. But deprescribing is what we call this sort of term where we're trying to decrease the overall use of medications. And so I'm going to continue to sort of call it deprescribing because that's really where the field has sort of moved to calling it. But deprescribing is tricky. I am a practicing pharmacist. I mostly do health services and implementation research. But as a pharmacist, this is really one of the trickier areas that we deal with, because a lot of these patients are chronically using these medications. They're for behavioral issues that are particularly challenging and have a lot of emotional valence behind them, things like sleep or anxiety. There's a lot of barriers from both the patient and provider side, but from the provider side, it's about obtaining patient buy-in and being willing to try to stop taking them. But there's been research to show that patients, sort of, if presented correctly, are open to trying to stop the medications. The other challenge is that with abrupt withdrawal could lead to some side effects, so you can't really just stop them right away. So there is often tapering or gradual dose reduction that's necessary for some of these medications, depending on the dose. And then in different sort of work examining what the other barriers are, is that physicians and providers often just don't have the tools and particularly the opportunities to really focus on these medications. Because there's a lot of personalization and individualization that goes into thinking about how to stop these medications for patients. There has been some literature focused on different types of interventions, particularly for these medications. They have been somewhat limited in some ways. A lot of the work has focused on the initiation problem. This is not dissimilar from the way we've thought about opioids. 5-10 years ago, when a lot of research was really beginning on opioids, is that the initiation problem is important, but the chronic burden is kind of where a lot of this lies. So a lot of the deprescribing interventions for benzodiazepines are really focused on initiation. Providers have sort of said there's like, I get notifications about these medications, but they don't really tell me what to do or exactly how to go about doing it. And the timing and the workflow has also been sort of insufficient. It's been at times where the patient isn't really in front of them, when the decision has already been made to continue them, just sort of insufficiently embedded. And then in addition to that, the trials themselves have had relatively small sample sizes. While sometimes effective, the interventions themselves have been relatively resource intensive, using lots of pharmacist time, for example, which really important, but the goal is to not have to do that, and to the extent that we might need to. And at least in my view, one of the biggest issues is that a lot of the trials that have been done of deprescribing interventions have been among patients who have already agreed to deprescribe. So there's just, even when you have a control group, there's just a different type of volunteer that's associated with that, which limits generalizability in the way we might think about what's effective. So a lot of what I try to focus on is using very pragmatic oriented sort of work to try to think about how we might implement things as they would be delivered in real world care. And so one of the avenues that we've been exploring for thinking about deprescribing interventions is not a particularly new side of tool for many. They're electronic health record based approaches. We've been known that these can be effective for a variety of different behaviors for years, but people overuse them. Clinicians always talk about alert fatigue. They have some modest effectiveness depending on the way in which they're delivered. They tend to work the best on sort of very discrete sorts of problems. And so this more thorny, longitudinal, deprescribing sort of problem is not where they've really been studied. And so some of the reasons why they haven't been overly effective is some of this alert fatigue I was mentioning, whether the content's really persuasive, whether it's addressing this clinical inertia problem of trying to get patient buy-in when they fire in workflow, and sort of what providers need to help them. And so these really could be improved with some behavioral science techniques, which forms the basis of really what interventions we're talking about today. And there's a lot of different ways we could optimize these tools with behavioral science. There's a lot of literature out there kind of looking at different types of behavioral principles and how they can be applied to electronic health record tools or different types of behavioral interventions. And there's many different types of principles that people have studied, that we have studied as well. So things like, what boostering or reinforcement looks like, cold state outreach, sort of addressing the hot state, cold state empathy gap, where people know what to do when they're in sort of a less stressful state, but they don't always know what to do. They may not make the same decision when they are in a stressful state. simplification, framing and salience, the way information is presented, defaults, like defaulting people to receive certain information, a concept called accountable justification, which is really having to justify to someone else why you continued to make a certain decision. All of these are potential ways we could optimize EHR tools. But there hasn't been a lot of literature to really suggest, particularly in deprescribing, like what might actually work. So that led us to really this sort of 5-year arc of thinking about electronic health record tools for deprescribing. So just to give you an example of salience and framing. So salience is just sort of raising the risk of what we care about. So increasing the risk of falling and making that sort of as precise as possible. Acknowledgement, reason, like having to justify what to somebody else what you might do, as well as a booster here where you're receiving a reminder. So there's some sort of booster that's going to happen to you later. And so our goal in what we call nudge EHR, which is really kind of, we call it novel uses of adaptive designs to guide provider engagement EHRs. It was a 16-arm adaptive trial that we just published this summer. That isn't a hybrid effectiveness implementation trial. And so we brought all of these ideas together, thinking that we want to test the effectiveness of different EHR tools that have different behavioral science principles embedded in them, and really try to figure out which ones might be the most effective on this problem of benzodiazepines, sedative hypnotics, and another drug class that also has risks. So we did this among primary care providers across 26 practices and a network here in Massachusetts, not Mass General Brigham, actually a different sort of more outpatient focused network. And so what it looked like was we had these different EHR tools that we delivered to PCPs for older adults chronically using these medications. And we defined chronic use really by having at least 90 pills of benzo or sedative hypnotic prescribed in the last 180 days. And so we didn't require informed consent to be included. Patients were included on the basis of their being eligible based on EHR data. And we randomized the providers. We also didn't require informed consent for the providers because these types of tools are things that people are quite familiar with and relatively quality improvement and orientation. So why do we do an adaptive design? Well, this comes down to the fact that we actually had a variety of different ways we could design the EHR tools. So adaptive trials are commonly used in drug discovery type work, where you're trying to do dose finding of potential oncologic medication or something like that. But we're also often in health services and implementation research trying to also figure out what the right dose of something might be. And so in this type of work, they might be particularly useful for interventions or adjusting how many patients to allocate to different arms. Maybe we can adjust sample size based on what the actual event rate might have been so far. We can study different multi-component interventions, seeing which pieces might actually work the best and sort of move those forward that look the most effective. Or drop inferior arms, which is what we had done in this particular trial, because we wanted to drop those arms that included electronic health record tool components that maybe really weren't the most effective. So some of these components were changing language in the alerts. We had a smart set order set that had different pieces in there that we had spent time with different clinician teams building out, which is kind of customizable tapering algorithms sort of based on the dose and medication that patients were taking. Patient instructions that were also sort of customized to what the tapering and dose reductions might be and what type of issue patients were dealing with. So whether it was insomnia or anxiety, different orders for medication alternatives, behavioral health, tips for providers to discuss deprescribing, and different in-basket messages at different points in time. And so there was different modifications off of kind of one of these. And so this was the one that was done at order entry, which is basically when providers were actually ordering the medications themselves. We tested different timing around this. And so you can see here that there were different pieces that we included, like changing the salience of what information was provided. We defaulted them to kind of opening a smart set and removing the order. there was a social accountability or accountable justification about like the only choices were to acknowledge the drug risks or leave a comment, and that there were different components in there, different tapering information, a variety of different things. Just to show you, because we were particularly pleased with how this turned out, this is an example of the handout for tapering medication, which providers seem to like a fair bit. And so the way this broke down across the different arms was that we had different components across the arms, and the way we had really kind of enough power to look at the different components is that we had kind of them across different arms. So we, in effect, tested these as factors. These different behavioral principles were factors that were included across different arms in different combinations. The one that was the most common is this column here called timing, where basically everyone alternated whether it was order entry or at the time of open encounter. And so open encounter is actually when the providers are opening a chart for the patient, typically to begin documentation on them. And so instead of firing at order entry when they were ordering the medication, we tested this timing of when they opened it in the chart. And so this trial, what we did was we basically identified and randomized 201 PCPs to the different arms. This looks extensive, but the whole idea here is that we had patients that were identified underneath these different arms that were differed somewhat in the behavioral interventions that they received. We took the data from this roughly 1,500 patients who were eligible and did an interim analysis on this. And so from this interim analysis, we dropped the arms that looked inferior based on the interim analysis and re-randomized the providers to different arms. In particular, that we identified new PCPs who were eligible, say they were new to the health system. We also identified PCPs who were in the usual care arm and randomized them to the more successful arms that were continued on, and so forth. So providers from these like less successful arms also got re-randomized. For this main analysis, we didn't include them in the study because we wanted everyone to be kind of newly exposed to some sort of tool. But the overarching idea is that we really consolidated down the number of arms that we had, and ended up with about 3,000 patients we had included in our analysis across both stages. So what our analysis looked like was that we used similarly electronic health record data to see what happened in terms of deprescribing or reduction in inappropriate prescribing. We identified patients who met our eligibility criteria and had a visit with the study PCP that they were randomized to. It was basically a composite of 3 different types of outcomes. One is discontinuation of an order, 2 is not having an order over follow-up, and 3, ordering a taper. And what I should add, and what may not have been clear, is we also had this kind of fully unexposed usual care group where the providers didn't receive the EHR tools, and they really formed the basis of our primary referent group. So we used a generalized linear mixed model where what we did was we evaluated these different intervention factors that were in the electronic health record tools. So kind of treating them like covariates, and looked at their association with the primary outcome, or this reduction deprescribing. And we pooled the data across those 2 stages. So there was clustering we handled, as well as there was some block randomization. We had fixed effects for what stage the trial the patient was in. And notably, patients could only enter once. So the very first time that they were identified as eligible, even if later they were still eligible across a different stage. So of these 3,063 patients who met our eligibility criteria, the average age was about 75 years and 2/3 were female. But otherwise, there were kind of a mix of eligible patients by virtue of a cluster randomized design across the different arms. But we weren't really looking at the analysis at the arm level. We were looking at it at the factor level. So when we consolidated across the arms, we had these 7 different factors that we included. So the timing, whether there was a booster, cold state, whether there was simplification, Sign-off approval was kind of a different one. We studied pre-commitment, which was, I'll explain that in a little bit, but really a tool that was designed to initiate a conversation with patients, rather than just discussing the need to do the discontinuation or the tapering itself, and just the way the information was provided. So 5 of these had advanced into stage 2 when we did this consolidation. And so when we consolidated across the arms, there were already some differences we could see across the arms in whether the discontinuation or the tapering happened and whether there was an order over follow-up. So when we did the actual multivariable modeling with the mixed methods, the mixed modeling approach, there was no significant difference in any of the actual outcomes on the column to the right. As you can see, there was a trend of some sort of improvement when you had these different factors compared with not having the factors. So for example, the one that was really the most promising based on, in part because we had the most power to detect this, was that we could observe really a 20% increase in the likelihood of deprescribing when the alert and the information was provided at the time that the provider opened the chart, as opposed to ordering the medication, even though that wasn't significant. When we looked at whether there was an order over follow-up, we did see an improvement. So we focused really on open encounter as a secondary analysis to dig into this a little bit more, because this seemed to be promising. And so when we dug into this more and restricted to patients sort of within the open encounter arms and looked at what happened, we definitely saw a pretty significant improvement in the likelihood of deprescribing for this pre-commitment behavioral principle, which is, again, one that I'll explain in just a little bit, but really where patients were kind of the primary focus of the information that was provided. And then a follow-up booster, where there was some information that was given in a subsequent interval for providers at a time to deal with outside of the office visit. And so we had also looked at different linked claims data and clinical outcomes that kind of had a similar trend of some sort of improvement, but relatively wide confidence intervals. So what the questions really are, and we just published this sort of why didn't it work? It's a few things that are a little different from what we expected, like the baseline rate was different from what we had anticipated. So our overall sort of usual care deprescribing rate was higher than we expected. So I think that was probably the primary driver. But we had also done an implementation evaluation to try to understand why it didn't maybe work quite as well as it could have. So namely, we did kind of 2 different things. We did a post-trial survey of the PCPs, where all of them were invited to complete a survey, and we also did some qualitative interviews. So the surveys were particularly helpful. We had about 85 providers who provided some sort of response, and they seemed to like the different components when they were presented to them. So 50% liked the patient talking points. A good number of them didn't actually know that some of these tools we had provided to them existed, but they found it helpful when we showed it to them in the survey. And so, there were lots of comments really about the patient wanting to stay on these medications and feeling like there was nothing more that they could particularly do. So after that, we did some interviews from the survey, where we interviewed 20 of them in more detail to really understand the problem a little bit more beyond what we could get from the survey itself. And so some of the things, shouldn't necessarily be surprising. It's like the providers knew that these medications were problems. Getting patients on board is a big challenge. Something that was really helpful for us to understand a little bit more is this concept of inherited patients. So patients that are from a provider who left the health system or retired, and so they inherited them and they've been on these medications for years. And so, having conversations with these patients to try to explain why the risks might be different now than when they initially started these medications is challenging. They also talked about how mostly they've just had conversations with patients, but did really like the idea of having handouts and giving them more ammunition to give patients, so more targeted talking points and things like that. And they also liked the reminder that these provided. They seemed to really like the fact that they fired at the time they were charting as opposed to ordering the medications on average, but really wish they could appear in different points in time. So other explorations of timing were sort of our big takeaway. So we kind of took all of this together and wanted to repeat to see what, now that we've sort of consolidated it down to figure out what behavioral principles might be useful if we had these tools in going in real practice, what might actually work. So this is more kind of hot off the press and under review, is we conducted a replication trial where the idea was behind this in our original NIA grant that we submitted was that relatively few of these types of EHR interventions have been tested outside the healthcare system in which they were originally done. So very deliberately ported over with the idea of actually testing those in another health system. While a lot of them, and this is true for them, use Epic in a relatively common EHR platform, they do still differ in some key ways, which we discovered a lot of kind of differences still as we were trying to keep these tools consistent as we move them over. So there are different avenues for sharing the tools, but things like culture and whether they use smart sets and different types of things like that really differ. But nevertheless, we really wanted to test the most promising ones of these that were identified from this adaptive trial in a different health system. And so that's what Nudge EHR2 was about. So the goal was the same. It was to understand whether behavioral science informed EHR tools improve deprescribing of potentially inappropriate medications. But the tact we went about to do it differed a little bit. So we already knew the two primary tools we wanted to test against usual care in this health system. So we did a 3-arm pragmatic trial of PCPs, still cluster randomized, to 3 different arms. So the first arm was this pre-commitment tool, which was where the EHR tools triggered, but the tools were really focused on discussing patient risks and giving a handout. And then a subsequent visit encouraged the deprescribing itself. So this is pre-commitment where it's usually a smaller ask and kind of pushes inertia in the right direction to do something small, like even discussing the risks and then trying to encourage deprescribing in a subsequent visit. We also tested this boostering idea, where there were EHR tools that triggered during the patient visits in this open encounter framework, but then sent a reminder in the in-basket 4 weeks later. The third arm was no tool, and we did this, like I said, in a different healthcare system several months after we finished the other trial. So what did these look like? Much easier to show 2 as opposed to 15. They kind of had a similar idea, but the first visit really focused on pre-committing to deprescribing, sharing a handout, and then discussing later. So we were really just promoting trying to share this information. And then the next visit, cued off of having shared that information, now are you ready to taper? Similarly, the boostering arm had this sort of remind me in 4 weeks where PCPs could set a reminder as a booster to remind themselves, and then at a different time got an in-basket message that they could say bring a patient back in for a visit or really start to address this at the next visit. So the outcomes were similar between the 2 trials. So they were virtually identical. It was among older adults who had been prescribed some of like a relatively high pill burden and had a visit with a steady PCP. And our outcome was basically the same, which was looking at the discontinuation of one of the medications, or not ordering an order during follow-up for one of these medications or ordering a taper. The only difference is that we added in another drug class, and it was really having to take 2 anticholinergic medications. So things like oxybutynin, for example, in combination with another drug like paroxetine, for example, that would fire as also wanting to deprescribe one of those 2. We added that in primarily to test generalizability of the medications compared with the first one. But just to highlight that we did actually change that about the drug class. But otherwise, the modeling approach really also still was generalized estimating equations, and we adjusted for provider level clustering, and in this case, really adjusted for multiple testing as well. So we had included 201 PCPs in total that we randomized to these 3 different arms. And identified roughly similar numbers of patients from these PCPs who are included in the analysis. So we ended up in total with just over 1,000 patients in the roughly 14 months that we were conducting this study. So it was also a shorter follow-up than the other study. And something else really to note is that between the 2 health systems, the age is pretty similar, as well as the female sex. There were more patients who were identified for anticholinergics. And I think those are kind of the highlights. Oh, it's not clear from the other one, but the number of patients was also pretty similar. So what did we find? Well, we found actually that compared with usual care, both of them were effective. And we found roughly a 40% increase in the likelihood of deprescribing the medication adjusted for multiple testing compared with the pre-commitment with usual care, and the same a 25% increase in the the likelihood of deprescribing the medication in the boostering arm versus usual care. So these looked pretty effective, and it was primarily driven from discontinuing the medication, also initiating a dose taper, but really just stopping the medication at some point over follow-up overall. So our takeaways, we just finished that trial last year, and it's currently under review. But our key takeaways are that there are some things that we can do, even in this chronic space of deprescribing, that seem to be effective. Doing these types of tools for providers when they're opening a chart for a patient, rather than the more conventional approach of doing it when they're ordering a medication, is probably more effective. 2, just assuming that we can address deprescribing in one visit may also not be the right approach. And so thinking more longitudinally is a takeaway for us here. This pre-commitment one, the one that was very patient-centered, likely laid the groundwork for future conversations. The boostering one probably worked by delivering some reminders outside of the hot state of being part of the patient care process. And I think it's important also to sort of think about how we can do more of these sorts of stage studies that help understand how we could pre-select different behavioral interventions and subsequently confirm that in another health system. But there are a few more things that we could do to improve the effectiveness. We could improve the implementation of them. We could also think about the way they're designed and actually kind of delivering to PCPs. So this is kind of now where we're moving and thinking about these things, because we know that there is a lot of heterogeneity in how PCPs use the EHR and how PCPs will respond to different EHR tools. So within the first health system that we worked at, we did some kind of post-hoc clustering based analyses where we found really 3 different phenotypes of PCPs based on sort of how they use the electronic health record in general, not specific to these tools, and found really big differences in how PCPs engage, whether they have scribes, for example, when they use the tools, how often they practice outside of working hours, those sorts of things. And so when we've now looked at those clusters and the relationship with our tools, we do also see some association between some of those work practices and how successful our tools were. So PCPs who seem to kind of write more notes, get in-basket messages, have longer notes, seem to have a little bit more effectiveness from these tools. This is highly exploratory, but something that we're thinking about in the way that we could deliver these tools potentially differently. And so that led us into thinking about how to combine some of these ideas. So we have our nudge EHR trials where we tested these different EHR tools and found sort of on average that pre-commitment and boostering might work, but we do note some heterogeneity in response to these tools. There are methods that we can use to leverage this different responsiveness. Things like machine learning or a type of machine learning called reinforcement learning that can tailor and personalize the way in which information is presented over time based on how people respond to that. We did completely separately a trial looking at how we could tailor text messaging for patients for adherence, and found that reinforcement learning, changing the text messages over time and personalizing them, did actually improve adherence. So we're now in the process of combining these ideas and doing a trial that we just launched called Reinforce EHR, where we're leveraging these two ideas and evaluating the effectiveness of actually adapting or tailoring the EHR tools over time to support deprescribing. So I'll give you a brief overview of where we're at with that, trying to combine some of these things. And so we may have an opportunity to improve the effectiveness of these EHR tools through personalization, because we know that personalizing content can improve health behaviors, particularly because there's a high variability in how people respond, as evidenced by the text messaging trial and sort of preliminary evidence from our EHR-based trial, as well as plenty of others who have looked at this type of work. And so reinforcement learning is a type of machine learning approach that uses this idea of observing individual behaviors in response to cues like electronic health record tools, for example, or text messages, and uses a systematic trial and error process to learn how to optimize response. And so we hypothesize that this approach might also work for provider prescribing, even though we haven't seen it used in this context. So the idea is that you send a tool, you observe an action like how providers prescribe, you evaluate the response based on the data you receive and different provider factors. And then the reinforcement learning algorithm selects and predicts a new tool that might maximize response over the next interval that you're looking at them. So our trial is designed to evaluate sort of the effectiveness of personalizing these tools in general over time using reinforcement learning on deprescribing. So we just recently cluster randomized 70 PCPs. The patients will identify of those 70 PCPs are the same in which we've been, the other trials have covered. But basically, we'll follow them up for 7 months and on a weekly basis, rerun this reinforcement learning algorithm and randomize and assign them to a new EHR tool. And so basically, the PCPs will receive these same types of electronic health record tools derived from the nudge trials to sort of guide their care for these types of patients as they're coming in need of deprescribing. And so the algorithm will feed in the characteristics and how they've responded to the tools and suggest a new EHR tool that the provider will receive. And so the components are actually all similar. We've decided to retain the order sets, the handouts, referrals, dose tapers. For simplicity and sort of a proof of concept, the tools mainly differ in just a smaller proportion of the behavioral principles that we tested in the nudge trial. So the way in which the information was presented and the timing of them. And we pre-built all of these prior to study launch, and we'll update the algorithm on a weekly basis based on newly extracted EHR data, and then the assignments will be recalculated at each week. And so the outcomes themselves are evaluated during the PCP visits over that week. But overall, we'll see the effectiveness potential. We'll observe and measure the effectiveness of whether this overall approach worked against usual care over the entire 7-month period. So the 4 factors that the reinforcement algorithm, learning algorithm will choose to select between are really the timing of the visit, again, this open encounter versus order entry, because for some PCPs, order entry might be the right time period. We just looked at the average in the prior studies. Whether they got a message beforehand, sort of reminding them about the patient, whether the information itself was simplified, and how the risks were presented. We really wanted to focus on things that could be measured within the day of the visit and unfortunately, we couldn't study pre-commitment or boostering because those would happen after and just got more complicated for the approach that we're trying to test here. But the overarching idea is that maybe we can see whether tailoring and using an algorithm to tailor these tools ultimately will find a profile of PCPs. And the overarching idea is that we could deliver them differently for PCPs depending on how they respond. Because rather than all PCPs sort of getting the same one, the ultimate goal would be delivering the tools that PCPs actually need in the time that they need them. So we launched the trial just a couple weeks ago. We expect to be completed in March, and hopefully we'll have analyses completed by next summer. And so with that, I really want to make sure to thank the relatively awesome team that I have here. I have a co-PI for the Nudge trials, Nitish Chowdhury here, who works with me here at the Center for Healthcare Delivery Sciences, and the work was funded by the NIA and R33, as well as a smaller P30 grant for this Reinforce EHR project. And so with that, I'm looking forward to any questions that you have, and thank you so much for your time and attention.
Yeah, thank you so much, Dr. Lauffenburger. This is the kind of work that I feel like I dream about doing, and then when you think about actually doing it, it quickly becomes overwhelming. So inspirational to see it actually being done. I'm gonna read off, it looks like we have a couple questions so far. The first one I saw was, how was randomization performed in the EMR?
Okay. So so the randomization of the PCPs actually occurred up front. So what we did was and this is for all 3 projects that I talked about. So we basically pulled down data about the PCPs and how many patients they had that were potentially eligible, what their overall practice size was, their patient panel size, and use that information to create blocks and stratified randomization within the block. So we did all of that really at the outset, having drawn the data from the EHR. And so the same thing actually applies for the weekly interval updates that we're doing for this reinforcement learning algorithm. We created sort of different macros and programming codes to pull in the data. And we're actually sort of processing that data, feeding it into the algorithm, and then it predicts a new one, and then we come back and change the EHR tools for them. And so it's all kind of happening outside the EMR, if that's helpful.
And then there's one that asks, did you also monitor patients' anxiety through patient-reported outcome measures or looking for any other escalations of patients' anxiety?
Yeah, it's a really great question. So we were trying to not intervene on patients as much as possible. And so we were not measuring what patients' anxiety levels were. We do, for both projects, have a data safety monitoring board, all 3 projects, I should say, where one of the safety outcomes that we're measuring and providing to them every 6 months as we're doing the study is the relative rates of anxiety that we can observe in the EHR. And so we didn't see any differences in the first 2 studies. We haven't had any issues so far in the week and a half that we've run the other study, but it is something that our DSMB is monitoring. And if we see any kind of big differences between the groups, they have the right to stop the study.
So Julie, I have a question.
Yeah.
So sorry, my internet is a bit unstable, so I'm off camera. So can you tell us a bit more about the implementation? First, is is it always like a effectiveness hybrid trial, or can you do it in a regular trial as well? Second, a related question is around adaptive trials. Is the implementation going to be, or the implementation strategy is going to be more successful in an adaptive setting or pragmatic adaptive setting? I'm just curious. And third is, where do we see the implementation strategies most frequently? 3 questions.
Wow. All right, Sam. It's great. Okay, so the first one I think is about the extent to which a lot of these projects are hybrid designs. So I deliberately introduced the first one as being a hybrid effectiveness implementation trial, which really there's different, so if you're not familiar with them, there's really sort of 3 levels of hybrid trials that sort of live between pure effectiveness trials and pure implementation trials. Where the pure effectiveness trials are that we're really not looking or caring about implementation at all. We're just looking at how well the intervention works. And then the pure implementation trials are, we don't care about effectiveness. So something like deprescribing, we only care about whether, say, the uptake of the EHR tools works. Hybrid trials live in the middle, depending on your focus of effectiveness or implementation. I have a new appreciation over the last few years for how most of the work that I do actually is a hybrid trial, when I used to think it was really purely effectiveness. And what I mean by that is a lot of these outcomes sort of in the middle about how effective something might be are really driven by how they're implemented. And so when we look at the fidelity of how the tools are firing, whether we look at uptake by the PCPs, like how often they chose boostering, how often they opened the smart set, how often they did some of these other things, which I didn't really have time to get into today. That's effectively implementation. And so looking at those is really critical to understanding why an intervention works or it doesn't. Because we found a lot out from our first trial about how they didn't know these smart sets existed. And so we've now gotten better at sort of figuring out how to explain where things are and those sorts of sort of implementation challenges along the way. And so I think all the projects that I showed you today have some sort of hybrid flavor to them. But the first one, because of where it's been done and how it's been completed, I had more sort of implementation data to share with you. The second question was about de-implementation. And I think the second and third were kind of about de-implementation in some way, which de-implementation is usually taking back a practice or a procedure or some sort of intervention that may no longer be effective or evidence-based. And it's trying to take it away, because most of implementation science is about trying to, a lot of the focus in the past has been about trying to take things up better or adopt things better or disseminate things better. And so de-implementation to some degree is some of the work that this is, like deprescribing. We used to think we should give benzos instead of hypnotics to people. And we've been learning over the last few decades that maybe we shouldn't be doing that. So taking away things taking away these medications is really a de-implementation sort of challenge. And I hesitate to call these EHR tools implementation strategies, even though I think one might bend the rules to think about them being strategies. I think they in themselves are sort of uptake or de-uptake sort of interventions, but they could be implementation strategies. And so I think you could look at these and start to answer some questions about what might be necessary to de-implement things like this. But the field of de-implementation and what implementation strategies are necessary, what will help, is just a lot more nascent than the overall field of implementation science in general. We think the strategies are similar and the approaches are similar and the implementation frameworks that we can use are similar, but we haven't sort of had all of the answers. So I don't know if Sam, that gets at what you're going for, but hopefully that helps a little bit.
Yeah, absolutely. And I think but it sounds like it's a very complicated field in itself. And so I think, understanding these entry cases is very important. And just
They're really good questions.
another related question, just, you showed us the use of EHR and you mentioned about it. Just out of curiosity, these de-implementation trials, can they be done without EHR-based setup, or I'm just thinking, and with all adaptations and everything, or is it possible to do it without them as well. And like in many low and middle income countries where I work, we don't have electronic health records set up. And there's a lot of the implementation need there where we can do with the trials like you did with the medication. That'll be amazing. But just thinking of a 16-arm trial with all the complications, is it even feasible in a setup where it's needed a lot? Any thoughts?
Yeah. Okay. Yeah. And you had a point in there about adaptation that I had sort of forgotten. Yeah, no, I don't know if I'll do another adaptive trial. It was super interesting to learn about, and the Spanish statistician that we worked with has done these routinely in cancer, which is why, we had this idea to apply them in this case. It was very helpful to study all these things, but I think there's some very specific situations in which they're useful. And Sam, you've identified some of the problems and why it would be more difficult to do them. One is that you need to be able to identify sort of patients over time. You need to have enough sort of a rolling basis, which you didn't necessarily highlight. Two is the outcome in which you're adapting on needs to be able to be measured quickly and extracted quickly. Because if you're trying to adapt on, say, a 6 or 12-month outcome, that's not necessarily going to work as much as something where you're looking to see what happens in the next week, or whether people have a response within the next month, or something in a much smaller time basis, let alone being able to pull the data effectively to have all of that quickly. The interim analyses took us 3 or 4 months, even though we could extract the data the day after the trial was completed, just between the cleaning and the, making sure all the data were correct. We had gotten all of that done. Our biostatistician did the analyses. Our data safety and monitoring board agreed to let us move on to the next stage. All of those things take time. And I don't think we're in a place where there's a lot of interventions in health services and implementation research where we could do that quickly. I do think anything sort of with data that you can draw the next day, patient-reported outcomes, if you're collecting this sort of overtime and REDCap, and you have that data sort of stored and you can do that quickly, I think that would also suit. But I think in a lot of the situations you work in, Sam, I think it would be much more difficult to do, both for being able to deliver, and I'm not an expert, you're the expert, but both in the ability to sort of deliver it quickly, measure it quickly, and extract the data quickly.
Thanks, Julie. That's very helpful. That was kind of what I was thinking, but I'll stop here. Thank
Yeah,
you.
we wrote
Actually,
Oh yeah,
ahead.
I was gonna say we wrote a paper kind of talking about these, and we didn't cover low and middle income countries, so I'm glad you brought that up.
So for those of us who are trying to do stuff like this, how do you get buy-in from a healthcare system to let you unleash an intervention on 200 PCPs? So, is it like the healthcare system risk management team identifies this as an issue and you say, hey, I can help with that, or was this your idea? Or is it like you're polling PCPs and they're like, this is a problem that we need help with? How does that come from, and where do you get the buy-in to do something like that?
A combination of it's a really good question, which I still, we struggle with all the time. It's like, what's a good implementation partner? Like, how do we think about these things? And so the biggest thing that I start with, and so in this case, is we had already collaborated with them on a different study. So obviously having some basis in which they trust you and you feel like, you've paid them well and you can support them and you're not going to do anything unethical. There's already some trust there. But even when there's not trust and we're building new relationships, it's still, each time we think about something new we might be interested in, we have a conversation and try to understand, like, well, what are your priorities now? Like, can we meet in the middle on anything you kind of find as a priority area? I'm medium agnostic sometimes to the actual problem. I think there's lots of really interesting and important medication use optimization challenges that I could imagine working on. And so if a health system tells me that this particular one is a really real importance to them, then maybe I work with them on how something I'm interested in studying could address those problems. And then usually it's like pulling in some of their providers and seeing whether that might work, and logistically, is that going to work? And in the case of these trials, it was like, well, we know how hard it will be to do this. We can adapt what we've done before. We're not starting from scratch. And so I think that was kind of back to the theme where I started, which is kind of building on other projects always makes things easier when you're trying to figure out whether something might be possible.
Does the funding to do something like this come from your own lab and grants and things, or is the healthcare system paying for some of it?
Yeah, the healthcare system is, providing some in-kind support in some way, but for the most part, we're covering it based on sort of grants and contracts or pilot funds or something else like that. And so we're going to the funders with some interest in demonstrated support and, experience working with them to some degree. And, most importantly, that they care about the problem and could execute on the problem. Yeah, and then usually once you have some funding in hand, there's a lot more ability to, I guess, figure out how to best address the problem.
And I have one more question that I'll use for the last 3 minutes here. Oh yeah, so you chose to tailor what factors you're using based on PCP style, which I think is really fascinating and just cool that you can do that in an EMR. And I love it. But I'm also wondering about the decision between going that direction versus looking at patient level factors or even environmental factors, like based on the kind of clinic, or if they were running, if people are running late on a certain day. Like I would think geriatric patients are more likely to be more medically complex. And if someone's more medically complex, I both have less time in my appointment to do anything about it. And they would probably most benefit from a benzo taper. What are your thoughts about looking at those kinds of things and why you went to the PCP side over the others?
Yeah, it's a really, really good question. So we wanted to do, like I said, do this proof of concept of thinking about how we could tailor or personalize tools over time. And the PCP side was easier and kind of potentially it worked based on the randomization that had worked best. It worked based on the factors that we had looked at from the PCP side already. And we could draw that data out kind of quickly based on the profiles and how providers practice. The computer scientist in our group really wanted to also tailor the tools based on patient characteristics, kind of reasoning just like you from a totally different side, that actually that drives a lot of the heterogeneity. And we looked at that briefly, and there was a fair bit of heterogeneity in the response driven both by the PCP and the patient. But logistically, we couldn't change the EHR tools as easily based on the patient responses, especially because we wanted to keep it consistent over a certain interval to allow the algorithm to see how the PCP responded over that interval. So we moved away from that for now, but I think that's a pretty important piece that, we would need to do if we were really to move this forward.
Right, well, thank you. It's 11:59. I think we got some good questions out of you on that one. Thank you so much for coming. I don't know, Sam, if you have anything left to add.
Thank you, Julie. Thank you. This was fantastic. And thanks, Trig, for moderating this. To all the audience, we'll see you for the next grand rounds in a month. Thank you, everyone.
Bye-bye.